Okay, this is the second podcast on types of shock. I apologize, I wasn't paying attention to this time, and I just had started talking about neurogenic shock. So, to recap, it's a loss of balance between the parasympathetic and sympathetic stimulation that results in vasodilation of the systemic vasculature caused by a spinal cord injury greater above the level of T6. Can also be caused by some spinal anesthesia or nervous system damage. The sympathetic nervous system is responsible for constricting, and the parasympathetic dilates, and we lose that ability to constrict. We lose the ability of the sympathetic nervous system to function and respond to such stress. The signs that we're going to get are hypotension with bradycardia. And this is a way to remember it because usually when we have hypotension, we have tachycardia. That's our sympathetic nervous system working. The tachycardia trying to compensate for the low blood pressure. Well, here, the sympathetic nervous system can't compensate, and you're going to have bradycardia. We have hypotension from the vasodilation of the vessels. Therefore, we're going to have warm, dry skin in the extremities. And basically what we're going to do for treatment is we try to restore that sympathetic tone. We try to stabilize the spinal cord, make sure that when we're positioning, we're keeping everything in line, and we're giving thrombus prevention for DVT. We are also supporting the blood pressure with vasopressors, and we are going to talk a little bit more in depth about neurogenic shock in 251 when we talk about spinal cord injury. And then we have the other type of distributive shock, anaphylactic shock. It can occur rapidly and is life-threatening and is caused by a severe allergic reaction. It's IgE mediated, immediate hypersensitive reaction to a substance, whether it's an antibiotic, dye, bee sting, latex, or food. What happens is it causes the mast cells release vasoactive substances, causes widespread vasodilation, capillary permeability. So then you have your fluid shifting from your vascular space out into your tissues, and you have vascular collapse. Our signs are they're going to have severe bronchospasms, hives, and angioedema in 88% of cases. 30% of anaphylaxis go into shock. What is angioedema? It is edema of your airway. When you have a non-IgE mediated response, it does the same thing. It has an antigen-antibody reaction, histamine's released, and you get the same response. You may not have those slides in your packet because I just had added them recently. Management. We need to remove the causative antigen if we can. We have to administer medicines to help restore vascular tone and stop that capillary permeability. Epinephrine. If a patient has a known allergic reaction to something, they need to carry an EpiPen with them all places. We can also give IM in the hospital. We do not give it IV for anaphylaxis. We only give IV in the case of a code situation. So we would be given the IM. Benadryl and steroids take a while to work, but Benadryl will help with that histamine response and decrease the histamine response, and steroids will help stabilize that capillary membrane and stop the permeability, and also help with the inflammatory response. Albuterol is going to open up the airways and make the airways less susceptible to bronchospasm and help with the breathing. So basically for anaphylactic shock, we're just going to manage airway, breathing, and circulation, which is our basic life support. That's why in nursing, it's important that we check for allergies, and that's why we drill it into you that you have to check for allergies. These patients need education about avoiding future exposure and how to receive emergency treatment if they do have a reaction. And then the last type of shock is obstructive shock. And this is caused by a physical obstruction to blood flow. And it is an emergent situation. 3 types of obstructive shock, 3 causes: cardiac tamponade, tension pneumothorax, and pulmonary embolism. Cardiac tamponade, you probably talked about last semester in 241. It's when blood accumulates in that pericardial sac around the heart, and it prevents it from giving an appropriate contraction, therefore decreasing cardiac output. The kidneys aren't perfused, so the urine output decreases. Things are backing up into this systemic system, so you're going to see the neck veins, jugular veins bulge. They'll be short of breath, tachycardic, and have a narrowed pulse pressure. And what do I mean by a narrowed pulse pressure? We'll discuss that in class. There you can see a picture of, let me fix that. See a picture of a distended neck vein. That is JVD. If somebody has a really thick neck, that's going to be hard to pick up. Decreased arterial pressure, muffled heart sounds. A lot of people have muffled heart sounds and don't have cardiac tamponade. Not a really reliable symptom, but that narrowed pulse pressure is. We are going to talk about tension pneumothorax in 251. So that's why there's no slides on it. But I will tell you, tension pneumothorax, basically, that's when air can get up into the lung pleural space, collapse the lung, and the air keeps accumulating, increasing pressure inside the chest. The air is getting in, but it can't get out. And what happens is that pressure that it increases in the chest starts squeezing everything that's in the chest. So it squeezes the heart. The heart can't contract properly. It decreases the ability of the heart to receive blood from the body, so it decreases your preload. And so therefore, with those 2 things, it decreases cardiac output. So that needs to be resolved to be able to have blood flow and adequate cardiac output. And we have a whole other PowerPoint on pulmonary embolism. So you're going to have a whole separate podcast on that. So we will discuss any questions in class. That is it for this podcast.